disclosures. So, as you would know, with the advent of precision medicine, there is the generation of hypothesis-free approaches, and we have these days a multiplex of biomarkers with which we try to predict the behavior of disease in a single individual. And metabolomics is another such tool. As you would have heard of genomics and transcriptomics or proteomics, metabolomics is special because it is the final common pathway for most processes. So it tells you actually what did happen versus the other process, the other omics, which say what might have happened. So metabolomics uses the resonance of hydrogen ion within a molecule and gives a comprehensive picture of host metabolic alterations. Now, we can measure it using either NMR or using LCMS, but NMR has some distinct advantages, as you can see, with potential for clinical use. So, although inflammatory myositis is classically thought of as an autoantibody-driven inflammatory disease, the first successful mouse model of inflammatory myositis was described where they found that at 1.5 months, when there were minimal infiltrates, the mice developed muscle weakness, suggesting that non-immune mechanisms might be important. It took Professor Nagaraju's group more than 10 years to decipher that this was actually due to decreased levels of AMP dehydrogenase, suggesting that deranged cellular bioenergetics are important in causing this weakness. And this has further been substantiated by in vivo imaging using phosphate NMR, where people have shown that phosphocreatinine is decreased in muscles which are apparently normal on clinical exam and even on muscle enzyme testing, but it can predict the onset of myositis in this clinically amyopathic individuals. So before I embark on this, I would have liked to introduce you to the analysis, but keeping time and interest, I'll give this a miss. So we tried to look previously at the role of metabolomics in predicting disease activity in myositis, and we found that healthy controls are distinctive. Myositis is distinctive from healthy controls, although DM and PM came in the same category, and myositis also exhibited differential clustering with respect to other diseases such as lupus. And later we learned that environmental factors are extremely important in this very sensitive technique, and fasting state can make a big difference in spared sera, and this set us up with the Herculean task of collecting fasting samples in this large cohort, which was not easy because being a tertiary care center, patients usually travel long distances to come to us. Previously, in the limited fasting samples that we had found some differences in active and inactive myositis. So with this study, we wanted to confirm our findings in a larger cohort and to identify changes in urine and muscle tissue, as serum metabolome could be a reflection of these. So we took 116 patients with fasting sera, and 114 of them had urine as well because menstruating or pregnant women were excluded, and 17 muscle biopsies from active myositis. We also took 18 healthy controls and 11 healthy biopsies, and 2 disease controls from infectious myositis. Muscle dystrophies, other muscle disorders, pregnancy and menstruating samples were excluded, and paired urine were obtained in fasting and non-fasting state to look at the effect of environmental factors here as well. So the median age was 34, and in our cohort, the largest size was that of dermatomyositis, although we did have good numbers of antisynthetase, overlap, and polymyositis as well. So again, we confirmed once again that myositis sera exhibit differential clustering from healthy controls, even in the larger cohort. And the sera metabolomes also differ in active and inactive myositis, and here the differences, as you can see, were in histidine, valine, mostly amino acids, although there were also differences in creatine, and also some of them in fatty acids, which we'll look at in a minute. So we found that in patients who had active disease, they had significantly lower creatine and creatinine, suggesting that this could be a surrogate for decreased muscle mass. And further on, there were changes in fatty acid metabolism. The polyunsaturated fatty acid, we get this peak at 5.31. This was increased in patients with active disease, and LDL-VLDL ratios were decreased. So PUFA has been hypothesized to be pre-inflammatory previously, and these ratios have been described as surrogate for CV risk. We also found that amino acids are increased, certain amino acids like phenylalanine to tyrosine ratio and glutamate to glutamine ratio. So this conversion particularly requires oxidation, suggesting there could be an underlying oxidation defect. So maybe there's a shift in metabolic processes from oxidative to non-oxidative metabolism. And looking at various amino acids, which a lot of them were significant with an excellent area under curve of 0.9, excellent value in distinguishing active from inactive myositis. Histidine, as we can see, it was decreased in active myositis as compared with inactive disease. When we looked at urine metabolome, it was different from healthy, mainly with respect to creatinine, which was again decreased in myositis, again confirming that this could just be a reflection of decreased muscle mass. And in fasting and non-fasting samples, the most difference was with respect to glucose, lactate, and glycerol. So mainly carbohydrates and fatty acids, which was expected, although active and inactive myositis were not different. I'd like to emphasize that we normalized all values for creatinine in urine. And so we try to look at the muscle metabolome, as that might be more promising and more reflective of the actual ongoing process. So healthy control versus myositis were distinctive, and we found that certain metabolites were different, like succinate succinate was decreased in myositis patients as compared with healthy controls. The creatinine was also different, but the predictive value was lower. And looking at this further, we found that glucose levels were lower in myositis, and there was increase in acetate levels, suggesting there's a clear shift to anaerobic metabolism. We also had 2 atypical patients who had initially presented as polymyositis, but later on biopsies we found that they had infections, and we thought that since sometimes infectious polymyositis can be confused, we tried to look at differences, and there appear to be some metabolites which are promising, which need to be confirmed in further studies. So deciphering pathways to metabolites, no difference in fasting samples were taken in glucose, lactate, or LDL, but branch chain amino acid, when they're decreased, it suggests they were decreased in active disease, suggesting that there might be decreased muscle mass.
Adhika, could you come? You exceeded time, so could you come to your final slide, please, so we can have some questions as well.
To conclude, we have low muscle mass and oxidation defect, which has been picked up by the sensitive technique. And serum metabolomics is useful, although urine metabolomics is largely non-contributory. And in future, we need to look at in vivo confirmation of these findings.